much ado. Ragini is not here, so we have Anand in his stead. So should we proceed? Organizers, anybody, any idea where Dr. Chandrakanth is? All right. So we all know the problem that of colorectal cancers, 50 to 60% will have metastasis. 80 to 90% of these will have irresectable liver metastasis. Conversely, 10 to 20% will be resectable. And if you manage to resect them, you can have a 5-year survival up to 58%. And I've just taken the chart from UpToDate, which shows you the optimistic series of the resectable colorectal mets. So I just start off with the first case. So this is a 56-year-old gentleman, diabetic, no family history of cancer, 6 kilogram sudden weight loss. Ultrasound was done by his family physician, which showed multiple liver lesions. Hemoglobin was 10.6, SGPT was 66, tumor markers were sent, of which the remaining were normal, but the CEA was 98. So directly he was sent for a CT PET scan, and I put up 2 representative images here. So my first question would be to our radiologist, ma'am. Would you agree that a PET CT would be the first line of investigation in this setting, or would you disagree?
I would disagree, sir, because considering that when we do begin with a metastatic workup, we would first like to go for an investigation which is easily accessible, and PET CT, so the most accessible investigative modality, I think, in all hospitals throughout is an ultrasound. And
which is done. So after the ultrasound, would you agree that
after an ultrasound, sir, we can do a PET. We can even do an MR for characterization. According to recent protocols, a PET CT as well as an MRI with specific sequences like a diffusion weighted imaging, and currently the use of hepatobiliary, hepatic specific contrast agents would give almost equal sensitivity. In fact, an MR with diffusion imaging and hepatic specific contrast agents has been reported to give higher sensitivities for diagnosis of metastatic colorectal carcinomas.
So that's an excellent summary. So if you're looking at the liver in particular, an MRI probably will give you more information.
Right.
But if you wanted to look at the whole body and see whether it's isolated to the liver or otherwise, then a PET scan would be a superior investigation.
Right, sir. According to the NCCN guidelines, I would say that what they have classified
is... So let's not get into the NCCN guidelines. We are in India. So our PET scan...
So for a whole body, a CT would be better. But for a hepatic evaluation for a hepatic specific therapy or surgical management, MR would be better, sir.
Absolutely. Yeah. So the PET directed the clinician that there was a hotspot in the cecum. Colonoscopy was done, which showed a very tiny growth in the cecum, which was asymptomatic, and the biopsy revealed a moderately differentiated adenocarcinoma. So, to the surgeons on the panel, can I start with Anand? Any benefit of resecting this asymptomatic small primary, or would you leave it alone?
So, the idea of resecting the primary is that if the patient will started on the chemotherapy for liver mets, so there might be the complication related to the colonic cancer. That's the hypothesis. The patient might complicate.
So in this specific case with a small cecal mass,
yeah. So
would you want to resect?
No.
Right. So that I think is the summary of discussions. So obviously, if you're obstructed or are likely to have a problem with the primary, it may be useful. And I put up the Japanese JCOG 1007 trial reference for the residents, RCT showing that there was no utility in resecting asymptomatic primaries. So I think the philosophical question is what makes a colorectal cancer med localized to the liver unresectable? Dr. Jain, and following that, Arun, would you like to take this?
So, colorectal mets localized to liver yet unresectable. One is the volume of the disease in terms of its spread across both the lobes of the liver. Then involvement of the intrahepatic major vessels. These are the 2 main situations where isolated colorectal liver metastasis may be unresectable.
One is regarding the distribution of disease as well as normal parenchyma within the liver. Secondly, some factors related to the primary itself, like a very high CEA, poorly differentiated primary. Then these are all in terms of, not planning a surgical treatment for liver mets.
Right. So I think in summary, it'd be fair to say that you wouldn't attempt a resection if you had a primary that was unresectable, you had unresectable extrahepatic metastasis, and within the liver, you couldn't preserve enough liver which is well vascularized and well drained as far as the hepatic veins and the bile duct goes, with enough parenchyma to sustain life. And that becomes a judgment which is individual, I think, from center to center, which is why there's a wide variety depending on how aggressive you are as a surgeon. So the next question, of course, is can unresectable liver mets be made resectable? And this is where we miss our oncology colleagues here. So before we go to that, a word about the molecular diagnosis. So Anand, in your practice, since we don't have the medical oncologist, I'm afraid you will have to be a substitute coming from a great academic institution. Which of these do you think is essential testing? I mean, all of them, none of them, what would you be doing?
So we are doing routinely MMR and MSI in these patients, and then depending on the thing, we will do the other investigation. But as a rule, routinely we are doing MSI in this on all cases of colonic and rectal cancer.
Right. Dr. Jain, Arun, any other views?
In our unit, only MMR and MSI, not much.
Same.
Only in selected patients, we will go to the NGS center.
Same with us, MMR and MSI.
Right. So we are evolving as far as the molecular understanding goes. I think it's sad that we don't have a medical oncologist here. But at least in my practice, MMR, MSI on all tumors, and certainly a right-sided tumor, there's no way to miss it. BRAF we would do, especially if we found an MLH1 mutation. But if you're planning an aggressive treatment, it's nice to know BRAF mutations because they don't respond very well, and you might save the patient plenty of money if you had that information. RAS wild type would be useful if you are considering cetuximab, but there are settings and that we can discuss the new EPOCH trial later on. And of course, immunotherapy is the new kid on the block. So if the patient is affording, and this is India, so we are not talking about NCCN guidelines, Western guidelines. A lot of the patients will not get government funding or will not have the funding to be able to afford immunotherapy. But if that's likely to be, then PDL1 testing as well as next generation sequencing would be worthwhile, which is our practice because we see a wide range of patients from the very well off to the poor class who come within our social schemes within our hospital. So I think that would be a fair summary. If there is any medical oncologist here, I would be very happy to have them on the panel because I think it's silly to have a colorectal med session without a medical oncologist. So I'll just run through these slides since we don't have its presence. So when you're trying to make the unresectable resectable, there would be chemotherapy, and Rene Adam way back in 2004 has published his series where out of over 1,000 patients, 133, which is 12.5%, actually went for surgery in what is really a very aggressive center for resection of colorectal metastasis. And 22% 5-year survival was noted in the operable patients. So this is overall 3% of the cohort. So in a few, they did manage to convert them into resectable. Falconi went a little bit further. So using triplet therapy with FOLFOXIRI, they managed to do a little bit better and get a 15% conversion to resectable. And now there's a whole host of new drugs on the market. And if any of you would like to comment, you're most welcome. But since we don't have the medical oncologist, the new EPOCH trial has actually demonstrated that using cetuximab for the KRAS wild type has actually made things worse by going ahead with resection after that. So that's no longer. So when we were younger, that used to be part of the protocol to rapidly downstage. That is no longer there. And there's a resurgence of bevacizumab, which has come in with the Cairo 5 trial, that adding it to triplet therapy, which is actually a very terrible regimen. So we subjected a few patients to that. They've not been very pleased about it. So any experience from the surgeons about operating in this group of patients who've had triplet therapy and bevacizumab? How long would you wait after the therapy stops? And what happens to the liver with this treatment?
So we have a few patients who had received bevacizumab and at least 6 weeks gap because of the potential complications of bleeding and all.
So 6-week gap. Yeah. So 4 to 6 weeks would be the minimum. And irinotecan and oxaliplatin happily tolerated. Would you review?
We generally wait for at least 2 months. Any patient after MAB.
Wow, okay, so you're even more conservative.
More conservative. And secondly, we select the patients very, very specifically. And third, most of the time, by this end of this all treatment, the liver usually behaves very bad. And the NASH and it looks like as if it is something like a child chronic liver disease.
Right.
At the end of all this therapy, especially with MABs and all.
Right. So irinotecan would give you more of the fatty liver, oxaloplat would give you more of the blue liver, sinusoidal congestion. But these are things to look for, and the imaging is very useful in trying to predict this and the liver function test. So some of them might be, difficult because you'll have to treat them almost like a cirrhotic, as Dr. Arun pointed out. I'll not go through the BRAF and such treatment. We don't have the medical oncologist here. So I think we're just sticking to surgical principles. Hepatic artery infusion has come back in a huge way, especially in America. $30,000 for the implantable port, and it's a very expensive way to give FUDR, which has 95% first pass through the liver. Any of you, any experience? Would you recommend this in your patients? Yep. So still not completely penetrated the Indian market. Yep. So I think of not many multimillionaires in India having colorectal mets, so maybe it'll come in soon. Chemoembolization. So you have the Deberry beads, you have, you can impregnate these beads. Madam, are you an interventional radiologist as well as...
No, sir, I'm a diagnostic radiologist primarily, but I've been a part of the cancer.
Right.
So TACE does play a very important role now for even selective embolization with chemotherapy delivery at the site of the disease does play a very important role. After conventional TACE, DEP TACE further fortifies the delivery and the super selectiveness, specifically when the systemic toxicities are high, or I would say even if surgical management is planned at a later stage to ensure that the rest of the hepatic parenchyma stays relatively functional. So percutaneous therapies as well as embolization does play a big role.
Arun, any...
Just one comment regarding TACE in colorectal liver met. We have used with something like a non-surgical intervention.
Yes.
Very elderly, frail person, unfit for a general anesthesia for any resection. At the same time, the lesion is big enough, not suitable for any ablation.
Yes.
Such patients, maybe 1 or 2 in a year,
Yes.
just like
so
that.
So for selected population, effective?
Yes.
TARE?
No.
Ma'am, any experience?
So it's tentatively done in a lot of onco centers. Like I've been a part of Tata Medical Center. We've had tests being done. Yattrium does have a big role. But it's expensive. The accessibility is less. So as I said, I would like to, for larger lesions where surgery is not an option, I think these options come into the forefront.
Usually as a third line, you have
Yes,
failed 2
yes,
lines
so-
of chemo.
Right.
You have an affording patient. It is something which has been...
If the patient can afford and if the system permits that, then TARE and TAREs do play a part. But that's always where surgery is not indicated, maybe, that way.
So we have the ultimate resection for this, which is a liver transplant. Again, we are missing Ragini here, so I don't know who would like to take the side of transplant for this setting. But the history would be the SECA 1 and 2 study. So we had Norway, PALDAG line, as you all know. They showed a very impressive 55% early survival, but 19 out of 21 had disease recurrence in SECA 1. They tightened the criteria and said if your CA is more than 80, and if you had progressive disease on chemo, you are not eligible. After that, you got a little better disease-free survival. but you still had a 60% recurrence in this group of patients. And now you had last year the publication of the TransMed trial. This is by Professor Rene Adam, and I put the conclusion at the bottom, which you can see, that validation of liver transplantation as a new standard option for the treatment of colorectal mets. Would any of you, this is the survival curve showing transplant above and chemotherapy below. Any comments by anybody on this?
Just a single comment. In Indian setup, transplant only for a very highly selected patient with living donor option.
Yes, so how do you select them?
I mean,
I can help you. So these are patients who have been on doublet or triplet chemotherapy. They're not progressing. They have a CA below 80. You keep a 2-month period between chemotherapy and transplant. And they don't have any extrahepatic disease after monitoring over this period of time, and the primary is out. So that is what was the TransMed study. And you have to time the transplant in such a way. Dr. Chandrakanth. So he's, well, we sort of finished all your questions, but I mean, welcome. So it's, yeah. Right. So in this select group, getting special permission to do cadaver transplants in that period where chemotherapy has not been used for 2 months, they found good success, but even their recurrence rates are still 60%, but they've been able to treat the recurrences. So maybe after 3 or 4 years, the survival curves will look different, but this is space to watch, but we obviously don't have time to go into this in great detail. So we'll go to the second case. 70-year-old diabetic gentleman, resected sigmoid colon tumor, T3N2, given Folfox for 6 months after the treatment. The CA and the CT was normal on 1-year follow-up. After 18 months, so now you have the primary removed, curative resection, you have a period where there is no detectable disease. 18 months later, the CA has become 12. The CBC is normal. The bilirubin is normal, however, the SGOT, SGPT is elevated, albumin is slightly low, the HbA1c is out of control, there's a grade 2 fatty liver, and you have this lesion, which is in segment 6, fairly deep, 2 centimeter lesion. Approaches. Sir, would you think of giving more chemo for this patient's, Dr. Chandrakanth? Or would you say directly go for some liver-directed treatment?
Right. So thanks for the question, sir. So this is a metachronous solitary metastatic lesion in the liver, and I hope there is no extrahepatic
No
disease.
extrahepatic disease. That's it.
So the benefit from chemotherapy to this sort of a disease is unlikely. So just a simple resection would be sufficient
so
for this
that is
patient.
fantastic. So you'd immediately refer the patient to the surgical team. Surgeons, resect, ablate.
equal results. I would say because of this location, maybe ablation first.
Any difference of opinion?
I would prefer a resection over ablation because it is a solitary lesion and liver doesn't look that bad, and presumably no significant comorbid factors. The results of surgery are good in such situations.
Okay.
Close to the main portal triad,
Yeah,
sir.
so the right posterior portal vein.
yeah.
So it's not the main, it's the right posterior.
Okay,
It's close to
posterior.
that. So you feel there might be
So surgical would be a better option, I think, considering that liver parenchyma looks better.
Yeah,
and
but it's a grade 2
close.
fatty liver. It's got raised SGOT, SGPT. Surgeons not looking overjoyed. So I've just put up 2 slides. This is not this case, but one of a well-differentiated HCC on the right and one of a colorectal met. So the key question is, how easy is it to ablate colorectal mets compared to HCC? So would any of you like to take that, using this as a sort of guide to tell you the problems that you can face with the colorectal met ablation? Or should I give you the answer since we are short of time? So in our experience, we find that colorectal mets tend to have more satellite lesions than you get here. So you can see that clearly here, that you can see a little satellite lesion here as well. While well-differentiated HCCs tend to be well encapsulated, completely localized to a segment. colorectal mets also tend to be more irregular. So it becomes a little more difficult to get a satisfactory ablation, and even a post-ablation CT becomes difficult. But certainly a 2 centimeter lesion, less than 3 centimeter lesion, you're absolutely right. If you think you can get away with it with a reasonable margin, and there's no harm trying it because you can always resect later on. So once you resect, then obviously you can't ablate later on. So the jury would be out on this. Ma'am, you want to say something? Or
So I would say that here the role of MR is very pronounced with like a
yeah,
better
so that will tell you very
workup
clearly
would
that
be-
it's a solitary lesion,
yeah.
and it will tell you the margins for which. But you cannot do the ablation in MR, so you cannot avoid the CT.
Right. So, that's
So
true.
you have to have the CT because
No,
otherwise.
but the planning would help, sir. With
Yeah,
satellite mets
the
and
MR will
everything.
tell you it's a solitary lesion. The MR will tell you the boundaries.
Right. Sir.
But only the CT will. You have to have a CT because that's your roadmap to your ablation.
Yes, definitely.
Right. So we move on to the next case, 65-year-old gentleman, bleed PRs, CA of 18, lower third rectum, so it's just above the dentate line, so clearly needs some sort of neoadjuvant treatment to handle. At the same time, 1, 2, 3, and 4 liver mets, but luckily all to the right posterior sector of the liver. So again, I would like to start with our oncologist. This is synchronous resectable disease that we are likely to cure this gentleman. You have multiple options. You have surgery first, chemo first. What would be your preference? Would you be happy with a surgery first approach, or would you say that I must try chemo, and if so, what?
Right. So this patient has synchronous colorectal liver metastasis, as you said. I hope this patient is not grossly symptomatic for the rectal lesion.
No,
If that is so, then I would start with systemic therapy for this patient.
just a mild bleed PR.
Yeah. So this patient has got liver disease already.
Yes.
So if you don't treat, the systemic spread will be higher. If I treat with rectum right now, you will have to have a chemotherapy-free interval of 3 to 4 weeks, which would defer systemic therapy. So first, any synchronous colorectal liver mets systemic therapy is the way to go. And the optimum duration is 2 months. You give 4 cycles of Folfox or Folfoxiri. We do not give targeted drugs for this. 4 cycles. At 2 months, you assess response. If there is a response, go ahead with surgery. This looks resectable.
Yeah. So what surgery that you
Right. So
are you happy to
stage
do-
surgery
are you
or
happy to do a low AR, ultra low AR with just 4 cycles of Folfox?
right. So after 4 cycles of Folfox, we must look into the response.
Yeah, it responds.
And if there is
60%
good response, then we should operate both the primary and the metastasis together.
So you're happy sending people for a low rectal resection with 4 cycles of Folfox? Would the surgeons be happy to operate on?
I think I would go for liver first resection followed by treatment for the primary in a second.
So tell us a little bit more about the liver first approach.
You mean?
What do you mean by the liver first? I mean, the residents.
I mean, yeah. So surgically, I mean, the resection of the liver, presumably the disease either is stabilized or responds to the neoadjuvant chemotherapy, for systemic chemotherapy. Then liver resection followed by treatment, again the chemo and probably radiotherapy for the rectal cancer, and then subsequent as a last step surgery.
So I think that's a reasonable approach in this patient because it's a two segment liver resection. Within 10 days, your patient should be fine. Then passed over to the oncologist. So either CT or CT-RT. Then you treat it as a rectum. And then at the end of that, you can decide what you would wish to do as far as the rectum goes, and then subsequently finish your chemotherapy and then see what you're dealing with as the long term goes. So neoadjuvant chemo, we discussed this. So you have synchronous resectable disease, right? So we also discussed the staged versus the simultaneous. So what is your preference? Supposing this was an upper third rectum, would you go ahead with a simultaneous, or would you prefer a staged?
So, I will prefer the stage thing. First, we will do the liver part, and after that, local treatment for the rectal cancer, we'll go for the second stage for the.
Any cases in which you would like to do a simultaneous resection?
In case of right colon disease, in which the risk of anastomotic leak and complication are rate, we can consider the simultaneous thing.
Yeah, so if it's a fit young patient, well nourished, low risk, and the liver resection itself is small, then it would be very reasonable to do a simultaneous resection. Both might be possible, laparoscopic or robotic or whatever technique you'd prefer. And this is the literature on simultaneous colorectal resections as far as that goes. So the fourth case is a 32-year-old gentleman, FAP with splenic flexure tumor, underwent total proctocolectomy and end ileostomy. 2 suspicious liver lesions were seen at that time, not investigated further. He was given 14 cycles of Folfox after this resection. At 12 months, the CA was elevated to 24 nanogram per ml. We don't know whether at any point it touched baseline. So this is within a year. And I have not put in the video of the CT because that's a bit difficult to interpret in such a short period of time. I have just put in this diagram to tell you. So you have this large lesion which is straddling encasing the middle hepatic vein. You have multiple lesions in segment 8. You have this lesion in segment 6. You have a lesion in segment 4. And you have a solitary lesion in segment 2. So you have bilobal liver disease. And the FLR for segment 2 and 3 is 22% calculated. Surgeons, any interest?
No interest. Higher. Ablations and follow.
What would you ablate?
See, the smaller lesions, then follow on the right posterior as well as the left.
No, so you would ablate 3 and leave 5 alone, or how do you?
The large MHV lesion, we will try to keep it as last to target.
No, but there is no way you can ablate that. It's encasing the middle hepatic
the other ones.
vein. So, but is there any point when you have a big lesion which is?
See, by the time maybe at the end of 3 months or 2 months, when we repeat an imaging, we will get to know the natural history as well.
Right.
Whether to go aggressive in this patient.
Any difference of opinion?
Since there is in the segment 2-3 there is only one lesion,
Yes.
and which is small, so I think we can try portal vein embolization in this patient with segment 4 embolization, and at the same time we can do the ablation of the segment 2 lesion. If and then we can reassess, and if the volume will increase to 35% plus, we might consider extended right hepatectomy in this
Could
patient.
I ask Dr. Chandrakanth that on Folfox you have this increase in size? Would you say that you want to step up the chemo? He's a 33-year-old young gentleman. You know he's unlikely to have the other genetic mutation. So he was BRAF negative, MSI, MMR negative. He's got an FAP gene mutation as the cause for this. Would you consider upgrading some chemotherapy, or would you say that try and do something for this?
So this patient has progressed on Folfox, and he has RAS, RAF, wild type and MS is stable.
Absolutely.
Right. So we need to look into the biology of disease, how bad it's going into. So this patient needs systemic therapy before embarking onto local therapy. So I would give Folfiri with an anti-EGFR for this patient.
Right.
So there is something like conversion therapy. If I give Folfiri with an anti-EGFR, they can reduce in size, and if the lesions respond or remain stable over a period of time of 6 months, then I will venture on to any type of local therapy. If I go for local therapy right now, in 2 months you will have another lesion. So it's not good to go local therapy.
Right. So that's an interesting. So there are two schools of thought.
Both for conversion, that is downstaging, and also to understand the biology, we would need a systemic therapy right now.
Right. So what would you expect your response rate on Folfiri, bevacizumab with failure of Folfox?
Folfiri EGFR. So if I want to give, if you want to shrink.
You mean cetuximab?
Right, cetuximab or panitumumab.
What did you think of the new epoch study of resections after?
Right, so that is in an obvious resectable disease.
But, I mean, technically, as
so the disease burden is little high in this
because
patient.
Anand has pointed out that technically there are ways to resect the disease.
Right. So the new epoch was.
I wouldn't call this unresectable.
So the new epoch was negative because it had a lot of big segment of obvious resectable disease. There it is. There it is no EGFR. But this patient, if you really want to make him convert to resection, you need response. If response is the end point, then we need to place anti-EGFR. So this looks almost unresectable. Bilobar liver mets for me.
So that is the brilliance of the tumor board. So your surgeon being Anand will tell you that this is resectable if I can increase the FLR. And you would probably respect that opinion and say, okay, you give it a try and see it can be done. If it can't be done, then we will think of the FOLFIRI plus cetuximab, as you very rightly pointed out. There are multiple ways to do it, including ALPS, two-stage resections, combining resections with RFA, which is not possible in this case. So what we actually did was, as Anand pointed out, a portal vein embolization. We were very lucky that in 3 weeks, we got a shrinkage of the right lobe. Now the left lobe became 38%, right? We went ahead with the surgery. The intraop ultrasound confirmed that there was a solitary lesion in segment 2, which we could take out, could do the right extended hepatectomy. But before that, we found that there was a solitary large Porter node, and the frozen said that's an adenocarcinoma. Would that stop your surgical resection, or would you opened, you put in the retractors, you find this node? Arun, you're smiling. So would you proceed? Would you give up?
This finding alone should not preclude resection because
So it will worsen the prognosis for sure.
We know that.
So that's an important message. So the old teaching was that you should give up, but certainly you're still going to be better off with resection than without. I'll just ask a radiologist, ma'am, very quickly. Are you surprised that this was not picked up on the PET scan?
Yes, sir. It should have been, but...
Yeah. So I think none of the surgeons are surprised because we all have experience that after giving chemotherapy for patients in FDG PET, the glucose receptor disappears from tumors. So just looking at the PET avidity doesn't tell you that there is tumor there. It is the anatomy.
The PET should have been interpreted along with the...
But then, you're
that
just,
was missed out.
I mean, the 1.5 centimeter Porter node, you're not going to...
Should not be missed out on the morphological imaging.
Absolutely.
Right.
And you're not surprised that it wasn't picked up because it just didn't pick up the glucose. So that was the resection. So just quickly in the last 2 minutes, the last case, 56-year-old gentleman operated for a CA rectum, similar. He had post-long course CTRT. He was lost to follow-up. So he was advised adjuvant treatment, which he didn't take. So he just had the capecitabine with the radiation. Weight loss 2.5 years after surgery. So he's been well in the intervening period. And again, RAS wild type, BRAF negative, colonoscopy is normal, and this is his picture. So now I think no one objects to Dr. Chandrakanth coming in at this point. Any surgeons would like to go ahead, though the FLR might be 30%. Any takers for aggressive resections at this point? What would you advise, Dr. Chandrakanth? Brief answer. We have
give the best systemic therapy possible along with targeted therapy. It's again, cetuximab will be a reasonable option for this patient.
No, surgeons tend to be eternal optimists. And no surgeon will tell you that this is inoperable. So,
right. So I would give anti-EGFR. This patient needs response. Otherwise, he will end up with liver failure because of cirrhosis. So if he's doing really well,
now he's platinum naive. He's never had platinum. So
right. So I can give good treatment. And if this patient has good response and remains controlled for a long period of time, then liver transplant should be an option for this patient.
Right. So that's an interesting take. So I'll just tell you quickly in the last what happened. So he was given 6 cycles of FOLFOX. The logic of our oncologist was that he's platinum naive. He had more than 50% reduction in tumor burden. So this is what happened. So you have disappearing lesions in segment 8, 2 and 3. Very quickly, first the radiologist and the surgeon, how do you deal with these disappearing lesions? Is it a true problem and what do you do?
So we'll combine modalities, I think, for if something which
so
was
you
initially
do an
documented
MRI.
on a PET.
Some may be picked up on
Yes.
MRI. PET never picks it up because the receptors
Yes,
have gone.
absolutely, sir.
And
So-
it's part of the CT.
So something which was documented on a previous PET and is now missing, even morphologically not looking very good on the CT component of the PET, we would, I think, another parallel modality for a better
If they were deep,
imaging.
you might want to put a coil inside.
Pardon, sir?
If they were deep, you might want to put a coil there before you gave the chemo so that you'd find them on table. Yeah. So
Yeah.
that would be our policy. Surgeons, leave them alone. Would you just ignore their presence and say, let's get on with it? Or would you try and dig into that area on table?
Disappearing means not completely pathologically disappearing. There will be some lesions, some active focus in between.
So you do your best to find it. If you can find it, you'd like to take it out.
The surgical approach to disappearing lesions will be based on the pre-treatment imaging as well as intraop ultrasound.
Right. So just to end, the left hemiliver was 36% FLR. Our imaging, MRI plus the PET showed only 2 tiny lesions in segment 4. Right. So again, we've discussed the treatment. So we went ahead with the right hepatectomy. We found all the disappearing lesions on the intraop ultrasound, which is a very useful modality for this, and we caught them out. What is the margin you would use as surgeons? What is the minimum margin when you're planning your resection, maximum margin, segmental resections? What is your philosophy?
I mean, as low as 1 millimeter is also sufficient these
But do you
days.
plan for a 1 millimeter?
No, I mean, it depends on the feasibility of getting a larger or a smaller margin.
So what would be your optimal margin?
Optimal margin
5 centimeters?
5 millimeters, 5 millimeters to 1 centimeter maximum.
Arun, what would you?
On table, aim for 1 centimeter. Practically, it could be 5 millimeter.
Yeah.
Histologically, it could be less than 1 millimeter. It's okay. A negative
So
margin.
I think that's the very practical truth, that you try for 1, you'll land up with 5.
Especially,
Yeah, and you'd hope for at least a millimeter margin, and MSKCC even has suggested sub-millimeter margin. So if, as long as you have 1 cell between the tumor and the resection, you might be better than not having a resection at all.
especially non-anatomical resections, circumferentially to get an even margin is
Absolutely. So
practically.
that's a surgical challenge that we face. Post-operative treatment, the oncologist has to have the last word.
At least for 6 months of treatment. What are the systemic therapy should be for 6
So
months?
you just complete the treatment that was there.
So transplant versus resection, what do you think is better?
No,
for
so
this?
we discussed the transplant
Right.
before you came in. So I'm sorry we had that. Yes, so I think we've exhausted the time. So colorectal met treatment is evolving. Imaging and molecular markers are the key. Upfront dissection and limited bilobar tumors tend to do very well. You need complex strategies for extensive bilobar disease, and an MDT meeting is essential. And I thank you to all my panelists for being very cooperative and agreeing with most things I said. Thank you.